Welcome. Happy EMS week, by the way, in case nobody told you that so far. That's why I got all dressed up today for you guys. So I don't know what happened with the communication, but you're supposed to get dressed up today.
I wore heels today. What more do you want? Not my boots.
Well, where do you want to start?
I didn't get the memo.
You didn't get the memo. Well, that's typical. You're too busy out in the alleyway. So I'm just going to talk about a little bit about medical director. I know Chris in the opening talked about medical director responsibilities. And for those of you that are involved in other programs, you see that the medical direction for paramedic programs is a whole lot different than what you see for other programs. And the reason for that is because the way paramedicine's developed, the way the certifying body has analyzed the process, and where those of us came from, what exactly was it that set us up for this? But in order to know what set us up for this, we got to go back and do a little bit of a historical perspective. We'll go back as far as Napoleon. We're not going back any further than that. So, Napoleon, they drug the bodies off the fields in carts, so you remember that one. And then in the World Wars, medical was deployed to the front line, so you got to be able to get shot at, whether it was going to be the corpsman, whether it was going to be the battalion aid man, whatever it was, but they were the people that were out there doing their thing. And then Korea, we had MASH, best care anywhere. You can hang that in the back of your ambulance too. That would be appropriate, I would hope, anyway. And in Vietnam, the genesis of the EMS white paper, which is kind of where all this came to be. That was in 1975. That whole process where, in case you're not familiar with that, the white paper said you could get better emergency care in the field in Vietnam than you could get on the streets in the United States. So that started to change the whole process, and we've turned things around. I think I said 75, it was 73 when that was published. So that's what's kind of set the stage for us to be able to get to where we are now. Now, some of you may have seen this before. If you trained around the time that I did, these were our training films, but when I was doing it, these were the originals. These were not repeats. So we were watching the original versions when they came out. But they were training films. We'd sit there and watch those. So my idea of training was go to the station, while we're in school this was, go to the station, watch this, go run some drills, watch another one that was on, run some drills, and then we go home for the night. And that was the way we learned it. Our preceptorship, if you want to call it that, was after we graduated. Because after we graduated, you walked in the next day, here's the keys, good luck, I'm out of here. Because there was nobody to precept us. So we've come a long way to try to get to the point where we've got both quality turnover, quality education, and quality experience. So, and that's the crux of what we do. Now, some things have changed in that whole process to allow us to become a little bit more comfortable. If you remember, if you ever watched either the originals or the reruns of Engine 51, they're always spending time on the radio. And those of you who I've worked with before know how I feel about the radio. That's not the place where you ask me to do something. That's the place where you tell me how you fix something. So we don't need to spend time on the radio. It doesn't take care of the patient. And it ties both of us up. So it doesn't accomplish anything. But some of my peers, still today don't necessarily agree with that idea. And the only way we're going to get them to change that mindset is to be able to, through better education, through better operations, through better reviews, through quality patient care, to get them to understand that we truly do well at the things we do and can make them happen. So the change, from my point of view, now some of this is opinion, you could call it professional or not, and I'll leave that up to you. But in my opinion, we need to decrease the amount of online. The online stuff, we can do online, and it's helpful for those situations. I know you guys never get anything you never saw before, but that's the time for online. Or you're in a situation, and I can remember having one of these, you get into a situation where you used everything in the drug box and it's still not working. What do I do next? The answer back then when I was doing it was put the mass trousers on, but, that was a long time ago. We don't do a whole lot of that anymore, except using mass trousers to float down the river. That's about the best use we have for them right now. Although, as many of you have heard me say, everything in medicine comes around. So we'll probably see him back. Aspirin disappeared and came back. Digoxin disappeared, is coming back. Theophylline, for those of you who got the dose of theophylline, it's going away and is coming back. So everything in medicine tends to cycle a little bit. So we may see mass trousers come back. Who knows? Don't know in what way, shape, or form, but we may see them come back. It was funny for those, just as an aside. Dr. Elefant, who's the new trauma director, who's planning on the survey this week at Williamsport, he and I went to learn how to teach a rural trauma development course. And in that book, so this is a newly published book. This is the 2018 version, I think it is. It has mass trousers in it for the equipment list. So sometimes things have a hard time dying. We can't put them away. We can't kill them. They just keep resurfacing. So we will see them, but they're out there. Okay. Reliance on guidelines and protocols. And again, I think those of you who work with me on a regular basis know how I feel about protocol. And we'll talk a little bit more about organization here in a bit, but protocols are okay. Guidelines, I think, is where we need to be, though. Now, the challenge is going to be, we're educating the student to be able to go, maybe out in the wilderness someplace. Not everybody's going to work in the state of Pennsylvania. So we've got to keep that in mind when we're educating. We've got to keep in mind, we've got to give the student the tools that they need to be able to function if they were never able to talk on the radio or talk to somebody until 3 days later. So we've got that responsibility to them. We also have a responsibility, though, since they're testing here, to be able to prepare them to be able to pass the test. So we've got those two things, and sometimes they're at odds with each other. I think all of us will admit that, particularly those of us who work here. So that is a challenge, but certainly guidelines, from a medical point of view, is going to be the way that we go. And if you wanted to take a step back and look at this, remember, again, for those of you who were educated by Dr. Miller, remember, we're teaching you medicine to be practiced in the out-of-hospital arena. We're not teaching you paramedicine. And there's a difference. There's a difference in mindset. That difference in mindset is you're the extension of what's going on at a fixed facility someplace. You have the ability to be able to go out and do these things. And you see that coming up now as community paramedicine starts to get established. Same concept. You're using the tools that you learned to be able to move them out to the field, but in a different venue or in a different realm or as a different call. But it doesn't change the tools that you learned. It doesn't change the knowledge that you have. It's just applying it in a little bit different way. So guidelines and protocols, we'll talk about that in a little bit. And then the training tools. Certainly, if you go back and look at the tools that we've used in the past and how we, whether it was going to be rolls of towels, with a little bit of rubber covering on top of it, if it was going to be a piece of plastic, it just, whatever you wanted to use as a simulator. The simulators we have nowadays are huge, are absolutely amazing, and have a lot of capacity to be able to use. The educational process that we have, the training tools that we have are far exceed what we've had available in the past. So we've got those tools. I would challenge all of you, the difficult part is getting used to this. And you guys, when you go to the field, are going to be challenged. You may have, and I'll talk about it also in a bit, you may have a whiz-bang student, who you're going to come up against who you may be challenged by. That's okay. That's all right. Learn from each other. That's the easy way to do it. Just remember, you're the one who is not getting graded by me, and they are getting graded by me. So just remember that. All right. Do you need to do something with that?
You can just click the end.
Oh, I got it. Okay. So to try to make sense of all this and decide what we're going to do with all this, or the way we work right now, the student is reliant upon you, to be able to guide them through this process, even though some days they may not seem very reliant upon you. even though some days they may just not want anything to do with you. So you're going to have those challenging days that you need to deal with. And we understand that. I understand that. You know, we deal with residents all the time. We deal with students all the time. So it's not anything new. The challenge is going to be, how are you going to motivate that student? I think, you know, Brady talked about engagement this morning. You know, what can you do to try to turn that whole process around? What can you do to make it better? The other thing that we've done, and it's not done for intimidation at all, but certainly medical direction involved in the classroom more. That's been one of the certifying bodies' goals, is to try to get medical direction available, to get the familiar face. When we do a site visit, you know, one of the questions, and it's tongue in cheek, but one of the questions is, do you know your medical director from the side of a milk carton, or is it somebody who really comes to class to talk to you? Because we ask the students that when we interview the students. You know, and it's important to have medical director involvement in this whole process, because that's where this is all built from. You know, we don't operate the process. Hopefully, if we're good enough, we can make the process happen and make it happen comfortably. Now, as part of that responsibility that I have and that you have, is we've got to maintain the accuracy. We've got to maintain the currency. You know, we've got to update each other on what's going on in medicine. We've got changing protocols. There's a new protocol change for Pennsylvania coming out shortly. There's a new skills update that's coming out from the feds here within the next month or two. Now, the good thing is you're probably not going to see, excuse me, probably not going to see a whole lot of changes from Pennsylvania's point of view, you know, but there are going to be some new things. And then we've got that whole new skill set for those of you who are getting more gray hair, you know, that may want to move on to community paramedicine. So now you've got a whole nother set of skills that you may need to hone up on or get used to using, that you may have learned a long time ago, haven't used in a long time, but now you may start to use again. But the accuracy and the currency are incumbent upon you and incumbent upon me to make sure that they're happening. Because that's the way we can get the students through the process. That's the way we can make it happen. That's the way we can make it a quality process. We support the accrediting and evaluating bodies. Now, there's been some discussion in the past. National Registry and COAMs, you know, are the two of them getting in bed with each other? And certainly in some ways it may appear to be that way, but it's not. National Registry will always be the testing agency. They will always be in charge of that, and a certifying body. What's happened though, and I was on the initial group from the board from COAMs, was to sit down and talk about this whole profile point of view. The concept behind the profile was, are there things that we can do that will make us more consistent across the board, so we have an even level baseline we can evaluate nationwide or even internationally, where everybody, you know, who says that they're a nationally registered paramedic has the same skills, knowledge, and effective behaviors. That's the concept. Those of you who've been around for a while, you know there are still some places in either the state or the country where you don't want to go drive. There's a reason why those maps were generated in the past. So as we've, you know, some people bring the quality up, you know, to where it needs to be, but establish a higher baseline is what we're looking to try to do. And then, you know, ongoing improvement in the educational products. We've got different tools. We're doing it a different way. Some of it's online. Some of it's, you know, the students required to do more reading. The students, you know, has access to electronic media as opposed to the old textbooks. When I went to school, it was basically mimeographed right before we had class, because that was when the course director got it from Nancy Caroline. You know, it was that day in the mail, by snail mail from Pittsburgh. So, you know, that was the way our class was. So we've got a whole new realm of information and materials to be able to do. We need to use them, but we need to use them with the intent that we're going to be able to get these students to where we need them to be. And then the simulation along with it. You know, we don't necessarily have to make up our own scenarios anymore, but what we do, and what I would challenge all of you to do, particularly if you're working in a lab setting, is to be able to get comfortable with the simulation. That's a lot of work. There's a lot of information there. There's a lot of skill there with that. But as you get more comfortable with it, certainly the student outcomes are going to improve because you're going to be much more comfortable with it. So where that all goes to is the validation. So from my point of view, validation starts on day one when we start to work through these processes. There's an instructor evaluation, there's a student evaluation, and they're evaluating each other also. but we've got to validate the processes. We've got to validate what's going on with that interaction between the two. Certainly, you know, and this is one of the discussions, and I don't know if Brady touched on it. I had to step out for another meeting, but where we start to do some peer-to-peer evaluations. That whole process, when you look at it, peer-to-peer is probably even more difficult from the student point of view than maybe instructor-student. Peers are going to be hard on themselves. They're going to be very hard, and sometimes too hard on themselves. So they may not have the educational background to be able to say or to evaluate, you know, well, yeah, that's okay. You know, my suggestion is do it this way. Peer-to-peer tends to be a little bit rough if you've ever watched it. And can get nasty at times. So I would challenge you, you need to work with that. So if you get into a situation where you've got a first year and a second year working together, watch that peer-to-peer, you know, see what happens. Make sure you're shepherding that process. We've been able to go back with statistics and say, you know, and that's where I know Chris had talked about a lot of the numbers that were developed, and you saw that whole long sheet of numbers. And a lot of that came from the certifying body. But what generated all that was to take a look at statistics over the years, over the number of people who've taken registry, over the number of people who've had a certified paramedic program, and to take a look at how many times did you have to do an IV until you were comfortable. Understanding there's going to be a range. There are people who are going to take 96 times to do one IV to get it right. And there are people who are going to do it one time and get it right and be competent at it. And then you're going to have that whole bunch of people in the middle. The way it was put to me, and certainly I don't propose myself to be an educator, but the aha moment, where all of a sudden there is a statistical point in space where the student has done enough of these things where from that point on, they will do well. You'll have an occasional miss. You know, none of us are perfect. But there's a point at which, with each individual skill that we do, that after they've done enough of those and done them supervised and done them in a controlled setting or with some controls around them, that they get comfortable. So, you know, if you think about that, you know, think about how many tubes it took you to get comfortable. Think about how many IVs it took you to get comfortable. For soul farts, how many times you had to put the mask trousers on until you got comfortable. You know. So, you know, there is a statistical analysis, and they've actually gone back and taken a look at, you know, how many times do you have to do, and some of the research that's been done with the paramedic programs. How many times you got to do a skill before you're comfortable? So that's what's generated a lot of those numbers. National Registry didn't like my next statement as a summary to that, but it basically, well, if we can do that, what do we need National Registry testing for? They didn't like that part, but if you think about it, if we really subscribe to that mindset, if we can say the patients or the student has reached their aha moment, why do we need testing? We've already validated that process. We've already said this is good. Now, it becomes incumbent upon us, particularly preceptors when they're students, but also supervisors when they're working in the field. You know, spot checks are going to be important. You know, you've got to watch and see what's going on. Certainly, you know, watching somebody who's got a high infection rate with their IVs. Well, what are they doing wrong? You know, are they using their dirty finger, you know, taking the glove off and using their finger? Do they forget to clean? You know, so what are the processes, you know, that are allowing them or causing them to fail? If they're not getting their endotracheal tubes in, what's different? What did they do different? You know, it's because they broke their wrist and now they don't have the power to be able to lift the scope up anymore. You know, what is the reason? So it becomes incumbent upon you as a preceptor and or supervisor to be able to take a look at that situation. What's the problem and how can we fix it? And get them back up to their skill level where they can start to function. Now, that's a whole standardization process. We entrust you to be able to say, you know, understand that there are standardized processes and procedures that we're going to do, but every student is going to be a little bit different. Either their perception of what's going on, their perception of what they were told, or their ability to be able to perform what they were told. All those are going to be a little bit different. So you as the preceptor have got to decide when you're looking at this, you know, is it being done properly? Will they accomplish what we're trying to get them to do in an effective manner that won't hurt the patient and still accomplish the goal? Because not everybody's going to do it differently. Wendy, do you do IVs left-handed?
I do.
Do you do IVs left-handed?
Yes.
Yeah. So everybody, you know, if you were going to analyze Wendy's procedure and the rest of you are right-handed, if I remember correctly, you're going to look at Wendy starting an IV and say you're doing it all wrong. Well, so, you know, you've got to, in your mind, be able to, okay, you got to turn things around. You're the teacher, turn things around in your head and say, okay, well, if I'm going to do this, we're going to do this way. No, you need to be able to analyze. They're doing it and they're doing it properly. It's just that they're doing it with another hand, a different hand. So, you know, you've got to be able to make the switch. Are they accomplishing it? And then we've got this other thing called personality that we deal with. You know, and the interpersonal issues. Did this just go off? That's all right. I'll stand still. I think you're right. So we've got these interpersonal differences, you know, where we need to deal with the student and the student's personality. So looking at your personality, you guys know pretty much what it is that you can tolerate and what you can't tolerate. Sometimes you got to put that in a box, put it up on the shelf when you've got a student who seems to be able to push all those buttons that you're having to deal with on that particular day. It may just be a single day thing. It may be a constant thing. But you've got to be able to analyze those personalities. And we're expecting you to be able to do this because you got to get the students through this process. And it's okay to go home and beat your head. Just don't beat the dog, beat the wife, spouse, or significant other. But, you know, you put it in the box and then go get it out of the box when you're done. Put it up on a shelf and you'll be able to get through this. We base all these things on previous experiences, our own experiences. Remember how you were taught to start an IV. You know, was it somebody that gave you a hammer and a nail, said, here, drive this into the skin? You know, or at least it seemed that way. Boy, they're pushing really hard. You know, was it somebody that said, you know, careful you don't go in at the wrong angle because you're going to skip all the way up the forearm. You got to be able to go in at an angle that you're going to pierce the skin. You know, don't do it that way. Pull back on the skin, push. And then you got this hand coming over top of you when you're learning. So don't forget the ways that you either learned or you didn't like that you learned. Because it's going to be the same thing that's going to happen down the road when you are having to teach somebody or work with somebody, particularly if you're trying to correct, because then it's an even more of a challenge. Because now you've got a person who either misunderstood or mislearned the process that you're trying to accomplish, and you're trying to undo it. And that we know that doesn't work so well, but we've got to be able to do that if we're going to be effective as preceptors. So you're key to the validation process. You are the people that are going to allow us to be able to say, yes, this student is competent, no, this student is not competent. If we ever get to the point that we're not doing national registry testing anymore, it becomes even more important, you know, because now I, from your eyes, need to be able to say, yep, this student's competent. You know, we've got their portfolio that'll show us that, you know, that they're going to be competent at that, but it's incumbent upon all of us to be able to say yes. So we do rely upon some consistency. There's got to be consistency across the board. We need to be able to say that the student can stick an IV, you know, in an arm, you know, X number of percentage of the time, be successful, do it cleanly, without trauma to the patient. You know, so that's what we're looking for. We're looking for that consistency and done in a manner which is not going to hurt anybody. So that whole quality aspect associated with it, which ultimately leads us up to be able to judge competency. The general public, and this is part of my responsibility, when I release somebody to be able to go, we're saying that they're not going to hurt the general public. And I'm relying upon you to tell me we're not going to hurt the general public. I can't go out with everybody on these calls. I got to rely upon you to be able to do that. So that consistency among student performance becomes really important. Encourage the student to establish a routine. The challenge is going to be when it's not your routine. They want to do it some different way. Is it going to hurt them? Is it going to hurt the patient? Is it going to cause problems? Or is it just different from the way you do things? And you've got to judge that. But encourage the student to establish a routine. Because if they get into a routine, the flow is going to be better. It's kind of like, if you want to look at it from a little bit different point of view, have them establish a routine for history taking. You know, that's why the whole sample thing came up. You know, it allows us to be able to say, we're going to take the history the same way every time that we do this. And that's okay. Sounds boring to us when we hear it, you know, 20 times a day. The patient's not getting bored by it. You're just answering their questions, unless they saw 2 students and a preceptor, then they may get it. But other than that, that history taking becomes very important. It allows for consistency. It makes sure we're not missing things, and it keeps the student out of trouble. It keeps us out of trouble and allows us to be able to better care for the patient. Maintaining the flexibility with the student, their own way. Let them establish, the goal here, and this is, I guess, I'll have to rely on the educators in the group, the pedagogy that we do to be able to say, you know, we're going to lead them, but we're not going to lead them to the way we've always done it. We're going to lead them to a way that's going to be effective for them to accomplish their skills, to be able to treat the general public, to allow them to fix those problems. So leadership, you know, eventually allowing a little bit more guidance, and eventually being able to turn them loose. And that's one of the challenges when Chris was talking earlier about, you know, we have a little bit higher standard. In order to maintain that higher standard, we've got to be able to accomplish all these things. We've got to be able to turn the student loose to be able to say they're not going to hurt somebody. And I'm confident they're not going to hurt somebody. And I'm confident they know exactly what to do in these situations. Let me see here. Oh, yeah, this is the other thing I wanted to talk about. No, one of my favorites, protocols. Chris asked me a question in an email over the weekend when he was looking at my stuff here and said, you know, what about protocols and memorization? Okay, so I'll peel back and I'll look at, if I'm flying an airplane and I have an emergency, what are the things I need to know here that's going to keep me from going there in a too fast of a manner? The same thing here. What are the things you as a paramedic need to know to be able to keep that patient from dying right in front of you? Those are the things you need to memorize. Beyond that, you've got time to look other stuff up, or you've got time to make some medical decision making. What's going to be the best route that we need to take? But there are a few things that you need to know up front that you can't be looking in the book for. Or if you want to do Johnny and Roy, you can't be calling Rampart to say, you know, do I have permission to start an IV and to put an endotracheal to that? That's a bunch of crap. Take care of those problems. Those are the things that need to be done right away if you're going to save this patient and keep you out of trouble, keep you out of court, and allow the patient to continue on. So those are the things that you need to memorize. And for each presentation, it may be a little bit different. So you're going to have to be flexible with the student. But it allows you to be able to do those things, do them in rapid order, maybe while you're doing something else, hopefully, if you've got them committed to memory, so you can start to work with the patient and get things stabilized. So the challenge then with the student is if they decide they wanted to memorize something different than what you did. Okay. This becomes a discussion point and probably not over top of the patient, unless they're going to kill the patient, then you need to step in and take care of that problem and then talk about it later. But you know, you've got to have a discussion, you know, what are your priorities? What are the things that you need to attend to that are going to allow us to be able to establish stability in this patient and to be able to continue to work with this patient as opposed to calling the coroner? Those are the things that you need to have. And through that rationale, I make it sound simple, but through that rationale, you should be able to get the student to come around to those things that need to be done and need to be done in a rapid fashion to make things change. So you need to guide them through this whole experience, but sometimes, and as uncomfortable it is for a preceptor, sometimes you need to let them go down the wrong direction. That will be the biggest teaching moment for that student when they realize, I did this wrong. If you're not going to hurt the patient, obviously, if you guys need to step in, you need to step in. But if you can, and the challenge for you is going to be leaving your hair on top of your head, not punching the student, not stepping on the student's toes, not stabbing the student with the IV needle, you know, not ripping the glide scope out of the student's hands, but letting the student go down the wrong road for a little bit, you know, will teach them more than anything else. Particularly, And this is that another one of those aha moments from a preceptor point of view that you can go back in your post-call to be able to say, what'd you do wrong? They'll get more out of that than they will out of anything else. The confidence builders are going to be when they do everything right all the time. The educational moments are going to be when they do something wrong that they have realized and that you can reinforce with them and allow them to be able to go back and guide them through that experience. But the post-call is the place to do this. As long as the patient's not endangered by what they're going to do. Certainly sticking an IV needle in an eyeball is not going to be an effective treatment. So either the students or the patients. You have those frustrating days occasionally, but try to get beyond them. Sit on your hands, bite your nails, whatever you need to do. But as long as it's not going to hurt the patient, try to work through them and get to post-call. And by then, hopefully, we'll have time to settle also yourself. So the final challenge. The final challenge is going to be medicine is changing. Well, like I said earlier, some of these old drugs that I was talking about are coming back. Medicine is a dynamic process and things will change over time. As a result of that, depending on how long ago you were in class, you may be getting a student that's got some new information you may not have. I would challenge you to learn from each other. I don't know that you can perceive how valuable it is for a student to be able to teach a preceptor something. Hugely valuable, particularly if it's received well and that interaction goes well. If you can do that, if you can establish that type of rapport, that you can have that good of a communication between the two of you, it'll be a great relationship. Things will go very well. Because then, now the road's open in both directions and you can have reasonable discussions between the two of you. It will allow you to be able to do that. So learning from each other is good. Obviously, keeping in mind that thing that's in page 1 of the EMT book, first do no harm. That's going to be the key to all this and allow us to be able to stay safe. So I would suggest, get the essentials done, get the patient controlled, get the student controlled. So you guys are doing a juggling act. You've got two things to handle, the patient and the student. And sometimes they're completely different problems and want to go in different directions. But be able to get to the point where you can start to discuss those and guide them through the process. So from my point of view, you guys are the eyes and ears of the program. You guys are the ones that make it fly. And we rely upon you to be able to give us the feedback through your grading, through your evaluations, through your observations. So all those things become very important to us. Now, what I would like to do is, if anybody feels so motivated, to talk about interesting student encounters. So times maybe when the student taught you something, times maybe when you had an impossible student and how you handled it. Because I think, the unfortunate part is, from a preceptor point of view, we all don't get to sit down and talk about these things. We're kind of in our own little silo, depending on where you're working, where we don't necessarily, except, sitting in a bar, complaining about it, we don't really have a situation where we can sit down and discuss these. So who wants to talk about interesting little encounters with students? JJ.
I've had situations where you'll have a student, you'll have an incident when you come back and you're discussing, you're talking about things to keep them to the standard, not to their standard, and they will have a rationale that you can't really validate at the time that, Breon will say, or Hawkins will say, or somebody will say, and it becomes, it puts you in a conflict, especially when you can't pick up the phone and validate those things right away. And then the other part of that is at times, it is very difficult sometimes to keep up with all the changes and I never want to give them bad information. I want to give them information that helps them. They actually can throw me off sometimes, not medically, but they can throw me off on their expectations at times. That's could be a bit of a challenge.
Anybody else suffer through any of that? How'd you fix it?
I have to go make contacts. I have a whole officer grade. it's extra work, but I mean, even sometimes in the classroom, in the lab, that'll happen. So sometimes the subjectivity of discussions, you're sharing experiences, whether it be other preceptors, other faculty, or whatever. Sometimes their interpretation gets a little off, and then I don't know. Some of their ideas get lost in the interpretation, and it creates some issues that end up chasing around.
That was, he used two words there that I should have thrown in here when I was talking about validity and flexibility. And that's objectivity and subjectivity. Because that's exactly what, that's the piece that I want to impart on you. There are objective things that we need to be able to do. And that's why we've adopted the grading systems and developed the grading systems over the last 20, 30 years to be able to do the things that we need to do. We want to be as objective with the student as we can, so that we don't have this preceptor poor reliability when we're evaluating the students. The subjectivity part comes, when we're trying to work through the post-call and talk about the issues that are going on, presenting them with objective facts and maybe an opinion on how they might be able to correct their problem. That's going to be the subjective part of it. But we try to make it as objective as we can, knowing that it's not going to be ever completely objective. And the silence fell over the crowd. Yeah.
I think one remarkable thing over many, many years in looking at the paramedic programs and legal support and college, there are now many students that I think we have bear witness to that in the moment or in the circumstance never felt we're going to make it. And I think through precepting specifically and guidance on the front lines, many of those folks have made it, and it's remarkable to see them later on at EMS today, to reconnect with them. And through each one of those little micro circumstances, like JJ's talking about, they become challenging because they create extra work, we use his words. But on the back end, it's not immediate, but distant down the line, they usually raise those cases in people who that moment. And it's surprising. They may not even have passed the program the first time, or they may not even have passed it here, and they may have passed it elsewhere. But the sense of appreciation in those cases, as you see them later on and witness their advancement, and success, I think that's remarkable to say in regards to the topic at hand. It brings value to it, value to the validation of the topic.
It wasn't necessarily for me, but was a female paramedic that I was witness to a shift change. And it was someone who had come out of the military, and he was giving him a pre-shift discussion. And, had a little bit of difficulty with his role to a female. And he was still, well, I'm military and I do it this way or that way. And sometimes that line of authority can be a little bit of a challenge. In this case, it just happens to be a military-oriented male towards a female. He didn't want to really accept his role. That could work both ways too.
Mm-hmm. Yeah, I think that was, I guess, what I was trying to say as far as being able to take some of the things that you have in your armamentarium and put them in a box and put them up on the shelf, because it's not going to work with this student.
I'll say this particular paramedic works up pretty well, Kristen. I mean, it's Kristen from that area.
There was a comment from Dr. Boyer about where the students stand when they enter the internship program. And that's still an area where I struggle to completely appreciate how far their skills should be. So as we go through the internship program, and the students that I encounter, which have been a lot, the vast majority of our calls obviously are low acuity calls, and they handle themselves very well. They ask the appropriate questions, and they're making appropriate decisions, and their skills are completely appropriate. And then you get one where all of a sudden you have to think a lot faster, and not only think about what's going on with the patient, but be thinking about what you're going to be doing next and next and next, and moving along and managing your time. And then all of a sudden, the student who's done very well for a couple weeks or a month or two, all of a sudden, hopelessly lost. And maybe you have 2 or 3 encounters like that. And so what I'm wondering through here is trying to decide what an objective grade should be for somebody like that. And as I think about even my own, I haven't been a paramedic very long, but I felt like it was close to a year before I really had a comfort level myself and dealing with difficult patients and cases. So help me through this a little bit as to how to treat the student appropriately and fairly.
I'll let Chris address the grading part. I'll take the easy part. The way I've handled those things in the past, this is me personally, I'm not saying this is right, but you get a resident or a medical student who comes in with the same type of thing. In the post-call, sit down, change the situation, and say, well, what if this would have happened when we did X? And it went a completely different way. What would we do? So basically, you're taking their experience that they've already had and trying to guide them through a different variation of that experience. That seems to have worked in the students that I've dealt with. I don't know that that's necessarily going to work for everybody, but it would allow you to be able to at least spread out the education a little bit and get them a little bit more in-depth thinking or a little bit quicker. The other thing is going to be, take that scenario and make it a drill, in off-call or post-call, do a drill and work through it, whether it's going to be a mental drill or if it's going to be an actual simulated call, and do that type of thing to allow them to be able to experience, okay, these type of things need to go a little bit quicker and you need to be thinking ahead because one of 2 things is going to happen with the next therapy. We don't know what it is, so we've got to apply it and see what happens. So, to get them to the point of stressing them. Now, hopefully, in the lab, we're able to create some of those situations to allow them to be able to anticipate those. Obviously, we're not going to cover all those situations.
So, the first thing I would say is we need to have an understanding, obviously, that the students won't function as fast as we do. And one of the hardest things we have as preceptors is we recognize something and want to intervene right away, and kind of getting that internal clock of, if it takes the student 5 seconds to recognize it's an airway issue longer than us, that's still okay. So kind of getting that barrier when we need to jump in. If the student's not catching it, we want to try to re-engage them in the call. So instead of telling them, hey, suction, say, I don't think his airway's speaking, what do you want to do? So they can get their thinking back on and just keep trying to readdress that throughout the call. But post-call, their grade is an objective measurement of their performance. So if you kept having to prompt them the whole way along, their grade should reflect that. I think one of the most important things as a preceptor to remember is students hang their hats on a grade. No matter what you tell them post-call, if they got a good grade, they in their heads did a good job. I don't know why he had all these discussions with me after the call. He gave me a 94, right? So the grade reflecting the performance sometimes is the impetus that the student needs to understand they need to change, and then couple that with some off-call remediation, simulation, et cetera. With the understanding that, especially in internship, most students, their first really sick patients, they're not going to do well on. They're just very stressed. They have all these things running through their head, and they have to develop an ability to follow the the script that we've given them in the lab, right? They do a bunch of really, really sick patients in the lab and simulation, and they learn a pattern. They're supposed to follow the pattern, and then all of a sudden they go out in the field and they're jumping all over the place. And the quicker they realize that if they follow that script that we've taught them, the better off they're. But that's, does that make sense?
It does, yeah.
You know, I can't tell you how many times I've had, because I meet with the students during internship every 3 weeks. And largely the reason I meet with them is to make sure they're on track with their graduation standards. You know, hey, you need like 6 more test bank patients. If you don't get them, we're going to have to go out in the field. But I'll ask them how they're going. And I can't tell you how many times I've had I had this really weird call the other day, and I sat for like a half an hour, and they were telling me how horrible I did. And all of a sudden, I got 90 on the call, so I'm not sure what his problem was. Like, they hang their hat on that grade. They think because they did well, as far as the grade goes, they did well on the call. And they don't quite actually internalize all of that feedback you're giving.
That's useful.
Anybody have a different way of handling it?
I think the one thing you have to give was bad grades, to reinforce with them that they weren't expected to come out here and get 100.
Everybody feels false.
I mean, they're there to learn. This is the practice rounds. I think that helps them to better learn. It helps them better put it in the perspective of not such a high expectation on them.
But they do hang their hat on the grades. That's for sure.
If you come in the lab, the very first question that they have after a scenario that I ask. Every student, very first question, no matter what. It's not how did I do? I don't think that went well. You know, how do you think that went? I don't know. Did I pass? Well, if you passed or failed, that's kind of irrelevant. I'm asking how you think that went. But they really, they're conditioned from the school system. If I did well, I got an A. If I failed, I got an F. And they hang their hat on that grade that they get on the call.
So you're in the position to be able to take them from the schoolhouse to reality. Or you could look at it from the schoolhouse to live or die. In a few cases, 5% of our cases. Anything else? Yes, ma'am.
Being relatively had situations that were life or death, pretty severe. The student kind of try to calm them along, they just kind of do that. My question is, like, how do you approach them and their blood interaction seems something like that? I've gone over it, but I've never seen something that severe. I'm never seeing
Well, hopefully, even though they haven't seen it before, if they recognize it, they know what to do with it. I mean, I wouldn't cut them a whole lot of slack. What I've done, students, particularly with a difficult airway, and I think you're going to talk about that a little later, difficult airway, and they can't get the airway. Okay, well, I'm going to stand right here next to you, and then we're going to put the airway in. I'll help you pull a little bit. I'll take a look down the scope. Now, you guys, you know, if you're doing video, you've got a great tool to allow you to be able to assist in that whole process. You know, me stretching my neck trying to look over the shoulder with no video is a challenge. But with the video, you guys can really get somebody tuned into what's going on. You know, a little tweak of your wrist. You know, a little change your tube position a little bit. That will allow you to be able to teach them. You've got a tool there that makes airway control amazingly, I won't say easier, but more effective from a teaching point of view as well as from an actual functional point of view. Yeah.
Just curious as like what your approach would be for the student on the opposite end that completely thinks that they know everything. You know what I mean? They come in there, I know everything. They don't have enough experience either. I think they're brand new back up. They tend to like belittle your partner in the ENT because they think, oh, I'm going to be a paramedic student. I'm better than the ENT. You know, I know more than you. I know more than everyone. What is your approach what do you recommend how to handle students like that?
I'd like to hear everybody else's opinion before I give mine.
So I can tell you that more often than not, that is them compensating for a severe lack of self-confidence.
Right.
So sometimes you have to try to weed through, is this really an arrogance issue, or is this somebody that's has such a large amount of doubt in their own personal skills and abilities that they compensate for that by looking with this big, kind of like the short guy driving a big car, right? But, you know, there are some times where, you know, if they think that, then I've had that happen in the past and make my partner be in charge of it, right? So, okay, this EMT's been an EMT forever. I would rather him run calls than most medics that I know. They're in charge today. You're going to ask them if we can go for lunch. You're going to ask them what we're going to do next. You're going to kind of learn that we're a team. Yeah, we're a team.
Yeah, I mean, that's the way I've handled those things in the past. Okay, I'm the student, you're the teacher. Tell me what to do. And usually after one or two of those, so things will settle a bit. So. But you obviously have to have a lot of confidence in what you're doing. And don't let them steer you wrong.
It also helps working with the EMT who is very knowledgeable.
Yes,
strong.
absolutely. 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 All right, we did that. So thanks for what you guys do for the students. I see Dr. Lazar is here. We'll take just a couple minutes, let him get set up. If coffee, bathroom, whatever you need to do, and we'll keep moving on. Thanks again.